Good morning everyone. My name is Akit Mirza and I am here to give a presentation on biomarker of cystic fibrosis. So let's start with the intro. Cystic fibrosis is caused by mutation in a gene coding the cystic fibrosis transmembrane conductance regulator CFTR protein, an ion channel regulating chloride, bicarbonate, sodium and fluid fluxes at epithelial surfaces. While there have been steady improvements in outcome, median predicted survival for a newborn with cystic fibrosis in the United States in 2014 was 41 years and median age of death in 2014 was 28 years. Cystic Fibrosis Foundation 2014 patent registry report underscoring the need for better treatments. Cystic fibrosis lung disease is characterized by defects in ion transport, mucociliary clearance, inflammation, bacterial infection, and airway remodeling that culminates in bronchiectasis and respiratory failure. CFTR may also cause intrinsic abnormalities in host defense cells, including epithelial neutrophils and macrophages. To advance biomarkers in cystic fibrosis drug development, the CFF has convened a cystic fibrosis biomarker consortium consisting of investigators with particular expertise in biomarker research. This document focuses on biomarker validation and qualification for assessing CFTR function and detection, infection and inflammation, examines relationships of existing biomarker to established clinical outcomes in cystic fibrosis, highlights new technologies for biomarker development, and summarizes area requiring further development. Now CF relevant pulmonary biomarkers, current status and opportunities. Progressive lung disease is the primary cause of cystic fibrosis, morbidity and mortality, and a critical target for therapeutic development. Several therapies have been developed to address cystic fibrosis lung pathologies, and their clinical use has been associated with improved outcomes. Accepted clinical efficacy measures in cystic fibrosis. Change in FEV1 has become one of the most established endpoints to demonstrate clinical efficiency in cystic fibrosis clinical trials. Pulmonary exacerbation risk frequency time too have also served as primary clinical efficacy endpoints, but typically require larger and longer studies to demonstrate treatment impact. Important secondary measures that have supported approval and clinical use of pulmonary therapies include patent reported outcomes, that is, for example, cystic fibrosis quality of life, revised instrument, weight gain and bacterial density. To date, no cystic fibrosis specific anti-inflammatory drug has gone through regulatory approval, and thus there has been little guidance as to what the accepted clinical efficacy measures will be for these agents, which have not produced the type of immediate and sustained FEV1 improvement observed with mucolytis antibiotics or CFTR modulators. Need for more sensitive clinical efficacy endpoints. Important gaps that have emerged include relevant outcome measures for patients with either mild or advanced lung disease and young cystic fibrosis patients who typically have both mild disease and poorly standardized outcome measures. Multiple breath washout testing and the lung clearance index, as recently published, has advanced a putative endpoint with greater sensitivity than FEV1 to detect biological effect in younger patients with mild lung disease and are currently included in several cystic fibrosis clinical trials. Imagining may serve as a correlate of a structural lung injury, that is bronchiectasis. The remainder of this review will examine the existing data supporting the validity and qualification of several biomarkers of CFTR activity, infection and inflammation, and the investigation needed to optimize these biomarkers for use in cystic fibrosis drug development. Here is the image which show the cystic fibrosis in a healthy person and a diseased person which is suffering from cystic fibrosis. So this is the trachea, this is lungs. So this image is inner part of a healthy person. of a trachea, that is a smooth muscle, lumes, traculus muscle. This is the image of trachea of a person suffering from cystic fibrosis. That is, in the trachea, the inflammation is there, the mucus secretion is increased, uh, and that's all. So let's move to the next slide. CFTR activity and ion transport in vivo. There are three in vivo biomarkers of ion transport which have primarily been used to monitor restoration of CFTR function. These include sweat chloride concentration and nasal potential difference (NPD) measurement and intestinal current measurement (ICM). Sweat chloride is a simple, portable, and reliable test of CFTR function that clearly discriminates between patients with minimal partial and full CFTR activity. It has been carefully standardized for both clinical use and for incorporation into clinical trials, and remains the mainstay of cystic fibrosis diagnosis. So here is an image of cystic fibrosis related lung disease, that abnormal CFTR. So it starts with inflammation, and this process is continued in the lungs. So here is the obstructions uh, that go with structural damage, bronchitis, pulmonary insufficiency. CFTR activity and ion transport in vivo. Different level of CFTR function quantified by the sweat chloride test also correlate with important markers of disease severity, including age of diagnosis, pre-newborn screening, pancreatic sufficiency, isolated male infertility, microbiology, and lung disease severity. Profound reduction in sweat chloride have been observed in all studies of ivacaftor monotherapy in cystic fibrosis patients with gating mutations. Intermediate effects were observed with ivacaftor in cystic fibrosis patients with the R117H mutation, and smaller effects in cystic fibrosis patients with two copies of the F508del CFTR mutation. Treatment with ivacaftor or ivacaftor lumicaftor. The effect of CFTR modulator on sweat chloride generally parallel the clinical benefits observed for these three populations. While individual changes in sweat chloride have not correlated directly with FEV1 improvements, aggregate data have demonstrated excellent assay performance and detection of biological activity. Further studies utilizing sweat chloride will need to monitor long term relationship between sweat chloride and key clinical outcomes in cystic fibrosis to support this biomarker as a key measure to accelerate drug development. The cystic fibrosis lung microbiome. Evaluation of the cystic fibrosis lung microbiome through unselected detection of 16S ribosomal bacterial RNA using deep sequencing methods is an emerging technology. Microbiome studies to date have generally shown that decreased measures of microbial diversity are associated with more advanced disease and may change prior to exacerbations. Methodological difference in extraction and sequencing, poor distinction of live vs non-viable bacterial DNA, and the lack of quantitation are current limitations to their clinical and biomarker use. Detection of bacteria using molecular method has enhanced sensitivity and potentially may reduce processing times, but monitoring of disease status and drug effect via molecular detection and microbiome analysis remains exploratory. DNA and RNA-based metagenomes or meta-transcription cryptomics, that is the study of the function activity of the transcriptome RNA sequence, have been used. The cystic fibrosis lung microbiome. Technical challenges include contamination with human genetic material and mapping of sequence data. Early reports indicate that DNA-based total and RNA-based metabolically active community structures so overlap for the predominant taxa, but less prevalent organisms may be metabolically very active. Further metabolic activities in cystic fibrosis samples show less patent to patent variation than the total microbiome and differ from results in other pulmonary conditions, and metabolic profiles of bacteria are dynamic with adaptation to the lung disease. Although limited to a small study numbers, early findings suggest change in disease status based on exhaled volatile bacterial metabolism. Biomarker of inflammation. Inflammatory biomarkers could play a critical role in the development of anti-inflammatory drugs and reflect downstream improvements in cystic fibrosis lung disease for disease-modifying treatments. They could be used in early phase studies to confirm the proposed mechanism of action of drug candidates. Alternatively, as correlates of clinical endpoints, they could help select agents for further phase 3 investigation. Results from previous cystic fibrosis clinical trials indicate that anti-inflammatory therapies may not result in immediate improvements in pulmonary function and but could slow the rate of lung function decline. This requires many patients being studied over a prolonged period to demonstrate efficacy, highlighting the urgency of identifying biomarkers that can more rapidly screen candidate drugs. Lung-derived biomarkers of inflammation. Due to drawbacks of bronchoscopy, the two most commonly collected biospecimens to measure inflammation are sputum and blood. Spontaneous sputum expectoration is generally limited to those with more advanced lung disease, adolescents and adults. Sputum induction inhalation of hypertonic saline improves sample accusation in individuals who do not routinely expectorate. Spectrum and biomarker measurements are reasonably comparable between induced and spontaneously expectorated spectrum. The validity of spectrum biomarkers as endpoints in cystic fibrosis clinical trials has been extensively reviewed. Neutrophil elastase (Ne) is currently the most informative spectrum biomarker to monitor cystic fibrosis lung disease. Spectrum neutrophilic elastase activity correlates with bronchiectasis in cystic fibrosis, tracks with and is predictive of further lung function decline, relates to treatment response in pulmonary exacerbations, and predicts time to next exacerbation. Increased BAL-Ne is also a predictive biomarker of impaired lung function and bronchiectasis in young children with cystic fibrosis. Other spectrum biomarkers that are associated with predictive of key clinical events in cystic fibrosis include calprotectin, uh, myeloperoxidase, high mobility, group OX1, HMGB1, and YKL40. Blood-based biomarkers of inflammation. Systematic inflammation may also link pulmonary and non-pulmonary comorbidities of cystic fibrosis. While there are less data correlating systemic inflammation with clinical outcomes in cystic fibrosis, systemic inflammatory biomarkers correlate with key clinical events, including pulmonary exacerbations and lung function decline. Circulating biomarkers have consistently changed more than spectrum markers of inflammation with exacerbation treatment, suggesting that systematic inflammatory measures may be more sensitive in short-term interventional studies focused on mitigating exacerbations. Based on results from a multi-center exacerbation study, serum C-reactive protein (CRP), serum amyloid A (SAA), and calprotectin declined during azithromycin treatment in a cystic fibrosis interventional trial. These reductions correlate with improvements in lung function and weight gain, providing indirect evidence that the changes were associated with clinically meaningful outcomes. Other candidate systematic biomarkers relating clinical status to cystic fibrosis outcome include neutrophil elastase, anti-protease complexes (NEAPC), various cytokines including interleukin-6, many studies, LGG, and circulating mononuclear cell RNA and transcripts. New technologies and tools. Omics-based biomarker development for new cystic fibrosis therapeutic. The use of omics-based tools to identify and validate biomarkers relevant to cystic fibrosis pathologies have only recently begun to be applied, and elevation to regulate biomarker use is not established. These tools allow for an unbiased analysis of complex cellular processes in a variety of substrates. Discovery of novel molecular biomarkers in cystic fibrosis has to date been limited, and the majority of discovered biomarkers represented acute response markers. Furthermore, no molecular biomarkers have been shown to reliably predict acute or chronic CFTR restoration. The advent of novel approaches in high throughput technologies coupled with advancements in analysis of big data may allow investigators to ask important questions with high sensitivity and precision. Omics-based biomarker development for new cystic fibrosis therapeutic. Proteomic analysis of cystic fibrosis spectrum discovered a relationship between myeloperoxidase protein oxidation and pulmonary inflammation, which was validated in BL. When the proteome of cystic fibrosis patient nasal epithelial was examined, a significant decrease in the expression of a number of anti-inflammatory proteins was detected. Proteomic screens have discovered a previously unknown mechanism for antioxidant downregulation in cystic fibrosis, namely NRF2 dysfunction. Follow-up biochemical studies in cystic fibrosis primary tissues linked this dysfunction to increased inflammatory signaling and demonstrated that activation of NRF2 in cystic fibrosis mice produced anti-inflammatory benefits. These results highlight the potential of non-based proteomic analysis in discovering novel biomarkers and previously unknown mechanisms of disease. So thank you everyone for listening me.